Welcome in, everyone. I'm so glad you're joining us for this deep dive today because we are getting into a fascinating, really transformative topic.
Yeah, we really are. It's a critical one.
It is. We are taking a look at a major women's health issue today, specifically vaginal vault atrophy,
Yep.
which is a huge part of what the medical community calls genitourinary syndrome of menopause, or GSM.
Right. And just to frame this for you, GSM can affect up to a third of a woman's entire lifespan. So this isn't some niche issue.
Exactly. I mean, we're talking about deeply impactful symptoms here: severe dryness, chronic irritation, and dyspareunia, which is the medical term for painful intercourse.
It completely alters your quality of life,
Hmm.
your physical comfort, intimate relationships. It's massive.
Yeah, and the medical community knows this, which is why we have this giant stack of sources to go through with you today. We've got scoping reviews, randomized controlled trials, actual clinical trial data, and direct insights from medical clinics.
All working on the absolute front lines of regenerative medicine.
Right. And our mission today, the core question we really want to answer for you is this: can a newer second-generation treatment called autologous platelet-rich fibrin, or PRF, offer longer-lasting growth factor retention and better healing than standard PRP for severe vaginal atrophy? Okay, let's unpack this.
Yeah, so to really grasp why PRF was even developed, we have to look at the gap it's trying to fill, right? Because the current gold standard for GSM symptoms is low-dose vaginal estrogen.
Which works well for a lot of people, right?
It does, it's highly effective, but there's a huge clinical gap. Estrogen isn't suitable for everyone.
Right, like cancer survivors.
Exactly, particularly those with a history of hormonally sensitive breast cancer. For them, estrogen is often just off the table entirely.
And beyond that, I mean, there's just a huge demographic of women out there who strongly prefer hormone-free options. They just want a different route.
Absolutely. And that's exactly what drove the field toward the first-generation regenerative solution, which you've probably heard of, platelet-rich plasma, or PRP.
Right, PRP, the vampire facial stuff. So from the sources, the whole idea with PRP is that it uses your own blood, right? Like a clinician takes a small blood sample, puts it into a centrifuge, and spins it at these incredibly high speeds.
Yeah, a very high-speed spin.
And the physics of that spin separates the heavy red blood cells out, leaving this liquid layer of plasma packed with your own platelets and growth factors, which is supposed to trigger wound healing.
That's the theory, yeah. And it sounds great, but the sources point out a pretty critical flaw in how PRP is actually made in the clinic.
Oh, right, the anticoagulant thing.
Exactly. When you draw blood, its natural instinct is to clot, right? If it clots in the tube, it turns into a solid mass and you literally can't inject it.
Which is a problem if you're trying to inject it into tissue.
Right. So to stop that, they have to add a chemical anticoagulant, usually citrate, into the tube. But here is the massive irony. The very first step of natural human wound healing is what?
Clotting, forming a scab.
Yes. So by adding that chemical to stop the clot, you are actively inhibiting the exact biological wound healing process you're trying to kickstart in the first place.
Wow. So you're left with just the liquid. And looking at the clinical data, standard PRP gives this rapid burst of growth factors, but it's gone within, what, 1 to 2 days?
Yeah, 24 to 48 hours, and the levels just plummet.
It sounds like pouring a bucket of water on a completely dry houseplant. You get this massive flood of hydration instantly, but it just runs right through the cracked soil before the roots can actually absorb any of it.
That is a perfect way to look at it. The physical structure just can't hold a sudden flood of liquid.
So if the atrophied vaginal tissue actually needs time to rebuild collagen and complex blood vessel networks, isn't a 48-hour window just way too short?
This raises an important question, and it's the exact biological puzzle that led scientists to develop PRF.
Platelet-rich fibrin.
Right, because that 48-hour rapid burst just completely falls short for sustained healing. So they changed the method to keep the growth factors in the tissue longer. And the shift in how PRF is made is surprisingly simple.
Just a different spin, right?
Well, a slower centrifuge spin, yes, but crucially, and this is the big deal, no chemical anticoagulants are added, none.
Just pure natural blood.
Exactly. And without those chemicals, the blood is allowed to undergo its natural physiological response. The platelets activate, and you get this process called fibrin polymerization.
Which sounds incredibly complex.
It's basically just the soluble proteins in your blood turning into long, solid threads. And because the spin is slower, those threads weave together to create a three-dimensional, cross-linked fibrin matrix.
So it's not a liquid anymore, it's like a gel.
Yes, a gel-like biological scaffold.
And the numbers from the clinic sources on this blew my mind. This fibrin scaffold actually traps and holds 8 to 10 times the growth factor concentration of conventional PRP.
8 to 10 times. It's massive. And it's not just growth factors getting trapped in there. The scaffold holds concentrated platelets, but also a huge volume of white blood cells, specifically leukocytes.
Wait, leukocytes? Aren't white blood cells just for fighting infections? Why do we want them for tissue repair?
It's a great question. They do provide localized immune support, which is super helpful for atrophied tissue that's prone to microtears.
Mm.
But beyond that, leukocytes actually secrete their own distinct set of growth factors over time.
Oh, wow.
Yeah, and the matrix also traps stem cell cytokines, so you're getting this multi-layered regenerative signal.
Here's where it gets really interesting. One of the clinicians in our sources, Dr. Arash Akavan, uses this brilliant fertilizer analogy. He says PRF isn't artificial. It's basically like fertilizing a garden by taking a highly concentrated version of your body's own natural nutrients, placing it exactly where the regeneration is needed, and that fibrin net holds it in place so structural change can actually happen.
Exactly. It holds the fertilizer in the soil, to go back to your houseplant analogy, but the real test, the defining metric, is the release kinetics. How long can that scaffold hold those factors compared to PRP?
Right, because PRP is basically the hare and the tortoise and the hare race. It dumps its payload fast and crashes in hours.
Yep. But PRF acts as a sustained release reservoir. The growth factors in PRF actually peak around day 7, and they continue releasing for up to 10 to 15 days.
15 days, that's a huge difference. What exactly is getting released over those 2 weeks?
Well, you have some heavy hitters. The most abundant is PDGF, platelet-derived growth factor. That's the main driver for cell signaling, telling other cells where to go and what to rebuild.
And the sources also highlighted VEGF, right? Vascular endothelial growth factor.
Yeah, VEGF is crucial for neovascularization, building new blood vessels.
Which makes sense because with vaginal atrophy, the tissue is basically starved of blood flow. That lack of circulation is causing the dryness and the pain.
Exactly, and building new capillaries takes significant time. You need VEGF present for weeks, not days. Then you also have TGF-beta-1, which normally, and this is fascinating when it's soluble, like in liquid PRP, it has a half-life of just 2 to 3 minutes.
2 to 3 minutes, that's nothing.
Right, but when it's physically bound inside that 3D fibrin matrix, it's protected from degradation. It lasts significantly longer. Plus, you have IGF-1 promoting overall cell survival.
I have to bring up this horse study from the sources because it visualizes this perfectly.
Oh, yeah, the equine in vitro study. That's a great one.
Right, so researchers took PRP gels and PRF samples, put them in a controlled environment to mimic the human body, and just watched them. By day 5, the PRP gels had completely dissolved in all but 2 samples. Just gone.
Just washed away.
But in stark contrast, all 12 of the PRF samples remained completely intact by day 5. The fibrin net just held its shape.
If we connect this to the bigger picture, you have to think about the target cells in atrophied vaginal tissue. They're called fibroblasts.
Was it build collagen and elastin?
Right. Exactly. And fibroblasts are slow-acting cells. They need time to migrate, attach, and start producing collagen. Giving them a 48-hour signal from PRP is like handing a construction crew a massive pile of gerst, paying them for 1 day and expecting a whole house.
Right. It just doesn't work like that. So that prolonged 7 to 15-day window directly translates to better tissue scaffolding, enhanced natural lubrication, and better mucosal thickness.
Biologically, it's a huge upgrade. But of course, we have to look at the reality check here. How does this actually play out in human clinical trials for women suffering from severe GSM?
Well, there are definitely positive signs. Like there was this 2025 double-blind RCT that showed really significant improvements in the female sexual function index total score over 4 months.
Yeah, specifically in metrics like natural lubrication, overall satisfaction, and a big reduction in pain or dyspareunia.
And there was another study where PRP and PRF matched topical estriol, which is a standard estrogen treatment over a 12-week tracking period.
That's all very promising. But looking at the medical journal reviews of the entire regenerative field, we have to be honest with the listener. The overall evidence base is currently rated as low to moderate.
Wait, really? With biology that strong?
Yeah. The studies suffer from some major issues. Small patient cohorts, follow-up periods that are just too short to judge long-term structural changes, and the biggest one, Massive heterogeneity, meaning everyone is doing it differently.
Okay, so let me ask you a pointed question. If a listener goes to a regenerative clinic tomorrow for this, are they guaranteed to get this perfect 15-day PRF scaffold we just described?
Absolutely not. And that's the pre-analytical problem. The specific blood collection tubes a clinic uses, the centrifuge speed, their whole preparation logic, it dictates the final product. A tube is not just a tube.
What do you mean?
Well, some tubes have silica coatings to speed up platelet activation. Some are plain glass, some are plastic. Plus, the centrifuge rotor angle matters. Lack of standardization means PRF at Clinic A might be vastly different from Clinic B.
Oh, I see.
And we also have to mention that in sexual function and pain treatments, the placebo effect is historically huge, and sham-controlled studies where they just inject saline are really rare here.
So what does this all mean?
It means that while PRF is biologically superior to PRP for sustained release, it is not yet the medical guideline standard. Low-dose estrogen still holds that title. PRF is best viewed as an emerging, highly promising, personalized therapy.
Got it. So just to summarize this entire deep dive for you, PRF is a significant biological upgrade over PRP. By ditching the chemical anticoagulants, PRF lets your blood create a natural fibrin scaffold that holds 8 to 10 times the growth factors. And instead of washing out in a day, it drip feeds those healing signals into the vaginal tissue over weeks, promoting genuine cellular regeneration for people who want or need a hormone-free option.
It's an amazing use of the body's own raw materials, but it does leave us with one final kind of lingering thought from the sources. Human plasma composition varies wildly by age, sex, and health status. Since PRF relies entirely on the patient's own blood, does the ultimate regenerative power of that scaffold depend on the baseline health, diet, and stress levels of the patient at the exact moment their blood is drawn?
Oh, wow. That's a profound point.
Right, like if so, could lifestyle optimization in the weeks prior to a blood draw be the actual secret to unlocking the ultimate biological scaffold? It's something to really mull over.
It really is.
Yeah.
Like, are you giving your body the right fertilizer to begin with? Well, thank you so much for joining us on this deep dive. We hope this gave you a clearer picture of your options and the science behind them. Keep questioning, keep learning, and we'll catch you next time.